All right. Good morning, everyone. It's my real distinct pleasure to present this brief slide deck on my research titled A Personalized Prediction Model to Risk Stratify Patients with Acute Myeloid Leukemia Using Artificial Intelligence. Okay, so briefly, no disclosures. An outline for today's talk. So I'm going to introduce acute myeloid leukemia, give a brief disease overview, and then the use of prognostication in the disease process and the treatment regimen. I'll then switch gears and give an introduction to artificial intelligence, a brief definition and history, a small demonstration, and then talk about some of the applications in healthcare. And finally, I will tie those together and I will demonstrate how we feel that artificial intelligence can be used to effectively guide AML therapy. All right, so acute myeloid leukemia. It's a heterogeneous group of aggressive blood cancers. They arise from clonal expansion of a hemetic precursor cell in the bone marrow. It's the most common of all acute leukemias and accounts for about 1% of U.S. cancer deaths. It's diagnosed by a blast percentage of 20% or more in the blood or bone marrow. And this is really an end-of-life disease for most patients. However, with appropriate therapy, 60 to 80% of younger patients can expect to achieve complete remission. And of those that achieve remission, about 1/3 of those will actually go on to achieve a cure. And when I say 60 to 80% of younger patients, I mean patients who are deemed fit enough from ECOG status and other factors to actually initiate the aggressive chemotherapy initiation regimen. All right, so importantly, the outcomes that are associated with AML are about 1/3 controlled by clinical features like age and sex and other things, and about 2/3 by cytogenetic and molecular features. Prognostication in AML determines the choice of consolidative therapy, whether or not we're talking about cell transplantation or chemotherapy. And to do that, to risk stratify these patients, we right now use the European Leukemia Net, the ELN. This is the gold standard for determining if a patient should either go for the bone marrow transplant or the chemotherapy route. And that's really determined by these kind of three different bins: a favorable, intermediate, and an adverse by the ELN criteria. I think it's important to understand how these stratify patients. So if you look at favorable, it's looking at certain translocations, some cytogenetic factors like that, a couple mutations, whether or not they have them. Intermediate, very similar. It looks at different cytogenetic features and mutational features, and adverse, the same thing, a different group of cytogenetic and mutational features. And I think it's important to note that each one of these are saying, yes, they have that particular cytogenetic relocation, whatever it is, or yes, they have that particular mutation. So that is what we're currently using in the clinic. Now, that best practice ELN classification has about a 75% accuracy, meaning 25% of patients are stratified into a different risk group and therefore probably didn't receive what we think would be the most appropriate therapy for them to give them the best chance of remission, prolongation of life, or even a cure. Now, there are numerous prognostic features in AML, and so how can you better characterize those? An idea of some of the features. Despite having obviously many, tens or hundreds of different cytogenetic features and tens or hundreds of mutational features, you have to consider all of the clinical features as well, like age and sex and white blood cell count and anything else that happens in the hospital. There are hundreds of features you can come up with that all may have some relevance for life expectancy and therefore should be part of a prognostic model. So that's a lot of data. What can we do with it? I think that's where we should talk about artificial intelligence. So, contrary to popular belief, this is not a new science. It's actually rather mature. It started in the 1950s. Thus far, there are decades of progress. And I would say right now we're in a golden age. And that's because we really have numerous open source, excellent packages that can be used by any clinician or data scientist who has a little bit of programming experience. And even those who don't have any programming experience. It's becoming more accessible all the time. And these packages are actively investigated, and there's new things coming out all the time. It's very exciting. How does AI differ from traditional statistics? AI, the whole point of it is to take a complex system, model it, and create accurate predictions from that model. Whereas statistics is more about looking at variables, the relationship between variables, hypotheses testing, these kind of things. I think a big challenge is that AI is the supreme buzzword part of science. You think of AI, you get robots, you get brains, there's neon colors. And this is really a difficult thing to overcome because in popular opinion and in layman's understanding, it seems very futuristic. It seems unsturdy, and even in the minds of a lot of reviewers, it's difficult to sometimes publish AI-related research, which is a shame because it has excellent data behind it. and there's lots of amazing applications. We'll talk about a few of those. So a brief demonstration. I explained that AI is really trying to get to the goal, to get to the end by whatever means necessary. Imagine you have a racetrack here like you have on the screen, and you have a car. The way AI works is it's going to take hundreds or thousands of attempts at something, and it's going to try its best. So imagine we have this car, and we just try, we give some parameters about speed and direction and ability to turn, and we say, have at it. And you can see that we just released thousands of cars, and they didn't get very far, some went backwards. Now imagine you take the cars that did the best, okay? You tell the AI that we're training here, look at those cars that did the best, think about, isolate those features, and retune, start over again, but put more emphasis on those cars. Let's try again. We put more emphasis on the cars that got further, and you can see the second attempt, the cars got a little further. So the AI was able to understand that we have these variables. Let's concentrate on those variables a little bit more, and maybe tighten the boundaries about what we think would be, an acceptable range. Do this over and over again. Each time it gets a little bit better until you get to the end where the AI is excellent and it drives a fast, moving car with no errors. This is, really the kind of the core behind any kind of AI application. We're just looking for the end by having it trained recursively over and over through many iterations from the beginning. Now, this is just a brief. I know there's a lot here. I just want to show you that these are each different clusters for different types of AI. AI is kind of grossly divided into machine learning as well as deep learning. And you can see that each of these white boxes on the periphery, these are actually different algorithms that you can currently use. So this is just to show that there's many algorithms with kind of different goals, what exactly you're trying to get to as your endpoint through your model. And so, it takes a little bit of doing to get to the appropriate algorithm, but there's many to meet your needs, and it's growing all the time. All right, so how is AI useful in healthcare? Let's look at this first one here, IBM Watson, a very big public consciousness for this entity. And really it's been great for improved organizational performance and actually to kind of bring AI to the forefront. We look at readmission, unplanned readmission risk calculators. We use them here at Cleveland Clinic. They're used throughout the world now, and they're getting better all the time. They model big data and help clinicians understand which patients are most likely to come back. Radiology. So now we're getting into an age where automated radiograph interpretation is more and more common, and that's simply done by artificial intelligence understanding of differences between images. Same thing for drug discovery. You can use unsupervised modeling to understand disease systems and look for novel targets, which can go all the way down to the level of looking for protein motifs that may be associated by looking at different drugs and things. It's very exciting. And then pathology, so automated microscopy interpretation, very similar to the way it's being used in radiology. Now, we talked about the ELN classification, about 75% accurate. And it's trying to model this very complicated system that determines a patient's outcome. Now, what if we try to use artificial intelligence to look at that complex interaction between all these prognostic features in AML? Perhaps we can come up with a more accurate model. I'd like to introduce my abstract here. So our methods, we started with a cohort that has 5 data sets. Each of these 5 data sets come from other centers. One is from Cleveland Clinic. One is from the Beat AML Master Trial. We have a couple from overseas in Europe, and one is from the Cancer Genome Atlas. We attempted to combine cytogenetic features, a panel of 44 gene mutations, and numerous clinical features. And then we chose a machine learning algorithm that's able to account for survival data. We did iterative feature extraction. So we'd make a model, we'd look at the features that were important, we'd kind of pare it down, try to isolate the features that are most important, and then we would compare it using a C-index. A C-index is a score that takes into account the confusion matrix of true positives and false negatives in these. And a score of 1 means perfect to fit every single patient tested, and a score of 0.5 means it's completely random. We use that to compare to the ELN. So just some descriptive metrics here. I think just a brief overview that we had about 3,500 patients. We isolated about 800,000 data points. And for each patient, those features, those prognostic features, we had 252. In the final model, we had 19. All right, a really quick understanding of how we did this. So you take all of the patient-related features like age and performance status. You take the disease-related features like the cytogenetics. Together, this makes all of the AML prognostic features. You feed them into the AI model, and you test and you create. And then what you do is you keep going back, and between building a model, evaluating it, and reducing the features, and you go back and build another model, evaluate, reduce the features over and over again until you get your final model that has fewer features, and ours had 19. What do we find? we found that of all those 252 features, most important was age, transplant status, white blood cell count, bone marrow blast percentage, and cytogenetic feature category, as well as these particular gene mutations. The C-index of our new model was 0.80, and that was significantly outperforming the ELN classification of 0.59. Now we took our model that we created and we reapplied it to each of the 5 patient cohorts so we could compare the C indices to see if it was extrapolatable to these different areas, because these are from different hospital systems. So you see here on the left axis we have C statistic, okay? Now there's the ELN of the 0.59, and here's our 5 different subgroups. And so you can see the C statistic is between 0.79 and 0.85 for each of these. And the blue there is showing how many patients came from each of those subgroups to create the final combined subgroup as 0.8. Now, I think that's very important to talk about personalization and interpretability. So I think one thing about this model is that it's very personalized. For each patient that goes into this model, we're looking at those 19 different gene mutation or 19 different features and how they interact for that particular patient. You'll see on this graphic here, I want you to look at the top. It has a 0 to 1 scale. This is the probability of having a bad outcome, having a reverse outcome. And this would stratify an AML patient. 0.5 would be a 50-50 chance, so it's anybody's call. And that's going to be represented in purple. And if it's a great outcome, that almost very unlikely anything's going to happen, it's a blue line going towards the very low probability of adverse. And if it's a bad outcome, it's a red line. And on the left axis, you can see that you have all the different features that were driving the model. Now, when I talk about interpretability, it's how did the model actually create this prediction? Now, that's something very important and difficult for AI because AI is typically thought of like a black box, and then you get all that buzzword status. And so it's really difficult for clinicians to visualize and understand how the model is actually making the predictions. And so I think that's a bridge that really needs to be constructed. So here's what we have. It's the exact same interpretation on the left. The left is demonstrating all of our data and how all the different patient outcomes. But if, let's say, we have a single patient and we want to put them into the model, you can do so just like this. So you can see that the patient is starting at a 50% of anybody's game at the bottom there. And as the patient moves up to each one of these features, as each feature is being taken into account, it adjusts what the overall probability is. Now you look up, it's kind of, most of these are zeros, which means that there weren't mutations found. And then it gets up to the blast of 26%. 26% is not that high. It's qualifying as AML at the 20% cutoff, but it's not so high. So it's favorable that it's not too high. So it takes a left turn towards a good outcome. And then you get to the white blood cell, 7.1, so-so. Then you get to the age of 18. That's a great prognostic indicator. It goes even more to the left. So you can see why that's, a patient has a favorable outcome. Conversely, this person, they had a mutation in an important gene. You can see how it takes a right turn there. A little bit higher, the blasts are 55%, another right turn, and the white count is 46,000, another right turn. And you can see why this person was stratified at a very high risk. So in conclusion, AML has an extremely complex interaction of clinical features, cytogenetic features, and genomic features. And the degree of complexity between all these certainly surpasses expert opinion, which is what was used to make some of these previous models like ELN. Our personal prediction model, which we call a clinical genomic model, significantly outperforms ELN with a C statistics of 0.8. And the particular features driving the model can be easily visualized for every patient. And I think that's important because it really leaves the black box of machine learning behind. Future directions, next steps, we're currently just finishing coding an online prediction server that maybe in the near future we'll make available. I would like to thank these 3 people who are indispensable to my residency here and to my research aspirations: Dr. Aziz Naza, Dr. Carlos Asada, and Dr. Abby Spencer. It's been an excellent time here at Cleveland Clinic, and I'm just starting my 3rd year, so I can't wait to see what happens. And I'd be happy to take any questions. Okay. Yeah, you can type any questions you have in the chat room. I'll be happy to answer them in a few minutes here. Okay, last call for questions, and we'll move on to some of the other ones. Okay. Okay, so Dr. Rothberg says, how did you account for the impact of treatment on the outcomes? Okay, so that's a great question. So impact of treatment, we do have transplant status in as one of our features, right? So one thing about AI is that if you're trying to make a model, you want to include as much data as possible if you're trying to model different points in the disease series. So this is not a model specifically only to be used at the very beginning of treatment. This should be applicable anywhere in the treatment line, before or after a treatment. And so this model can be used in the beginning to risk stratify prior to having something like a transplant. But even after a transplant, we still want to be able to use this model again and understand the outcome. Now, AI is smart enough, if you give it enough data, to be able to make those kind of decisions. It'll create within itself cohorts of information. One would be like pre-treatment, one would be post-treatment. And so the model should account for that if it's powered high enough. And given the number of patients we had, we think it was sufficiently powered. Of course, it'd be even better if we could have additional patients in the future with more collaborations from other universities and things. And so that's something we would consider. Yes, Dr. Spencer. How do patients feel about the use of AI in the care of diagnosis? Okay, that'd be an excellent question. I certainly haven't actually talked to patients about using this yet. This is translational, has not yet been used in the clinic. But I would say that much of a lot of things that we're doing now already uses AI. If you look at our own Epic EMR, when you do your discharge summary, it creates that risk calculator at the end. That's certainly based off of a machine learning algorithm. So I think that it's going to be something that's going to be met with a lot of trepidation, because, like I said, the supreme buzzword status, it's very difficult for that. But the science is sound, and we use a lot of the same kind of quality control measures that any other part of medicine would use. So I would hope that we could assuage those fears by explaining that there's the same amount of rigor in what we're doing here as anywhere else, and that it's not a black box, that we're doing it very pointedly in order to get particular outcomes. Okay, I'm going to pass it on. Thank you.